Okay, good morning, everyone. So we're gonna start the session Power Session 2.2. So this is the focus on sustainable financing, and you see the plenary too. That this health finance is one of the plus the challenges on this aging population and demographic transition. So that I believe this is one of the most important session for us. So good morning, everyone. So distinguished guests, welcome to our session called Sustainable and the Future of Health and Wellbeing for All and All Ages. So focus is sustainable financing solutions. So this session is organized by the Asian Development Bank and also National University of Singapore as a co-lead for the session. And we are happy to also invite all the colleagues focusing health financing agenda for the interactive discussion today. So my name is Akihito Watabe. I'm the Asian Development Bank health specialist focused on health financing and also International Organizing Committee of the PMAC since last year. So we are going to be the moderator together with the Kiesha, my team in this session. So yesterday we saw the video, of the very moving story of the story video, but also they say in the PMAC video messages was that this life is more than the number. That's a very nice message, but I was not sure it is also relevant for ADB. So I asked ADB's AI chatbot. So it's PMAC say the life is more than the number. Is this true? And what is the perspective of ADB? So the answer is ADB sees life as a fundamental more than numbers, but number help us capture and improve the human experience. So ADB's development philosophy blended kind of a qualitative metrics to track the accountability, equity, and results, and also qualitative value-based dignity focused on principles such as to ensure that the development is truly about people. So in other words, number are tools, not the truth. The truth is a human well-being. So I'm glad to see that the ADB's AI answer this question very nicely and probably diplomatically. But also, we want to discuss a little bit number today, how we can address these challenges in the demographic transition. So can I show this slide on this? Right? Yeah. Okay. So this session focusing the critical focus on the sustainable financing. So we are now in the very critical junctions. So we just about 5 years left before 2030, which is the SDG target. And of course, everyone know the SDG 3.8 is a universal coverage. And we try to increase more financing for access to healthcare and also protecting the financing access and financial risk protections of the people. But also we experience global landscape is being changing and is reshaping how we can address the aging population, but also urbanization and migration. And also these development challenges now that how we can address this volatile geopolitical environment and those huge cut of the external aid in health sector and others. So we need some call of actions for this these changes. And we had a special session focusing on the financing, global health financing this Wednesday. That was also the part of the discussion. So the special session focused more on the global aspect of the global health financing. And this session focused more domestic aspects. So we have more country speakers, including the high income and also middle income countries, to showcase some of the domestic experience and also how we can address the external shock in the domestic perspective. So this session focusing on the revenue raising and the pooling, that is one of the health financing aspect, but also innovative financing model, how we can raise funding, but also how we can purchase services more effectively and more effectively and then qualitative, improve the quality of services. And also financing is not just the one aspect of health services, but also how we can provide the life course approach from the babies and the adolescents and the working age and then aging populations. So we need to provide the services more comprehensive way and how the health financing can support this life course approach. So today's session, we're gonna start the one keynote speaker and then have following by the panel discussion. And we also cover two case studies from Indonesia, from more on the for-profit and also non-for-profit private sector's perspective to have a more truly interactive dialogue. So we will start the session with the presentation of the Dr. Jonathan Silas. He is a LSE practice professor and also LSE Hub Coordination of the European Observatory on Health System and Policies. So welcome to the presentation.
Thank you, Aki. So I'm very happy to open this session with this hopefully motivating presentation about why aging or how aging affects the ability to raise money for health. I'm going to talk also about what the implications are if we don't raise enough money for health, and then start to propose some possible policy options. A lot for my 9 minutes allotted to me. But let's see. So I think we all know there's a lot of challenges raising enough money for health, not least this guy. But across the world, countries are facing political challenges. There's limited fiscal space for health because defense, also because of this guy, is crowding out space for spending on other things like health and social protection. We heard yesterday in the opening ceremony about informality. And actually, I was surprised. I didn't realize that 60% of workers are informal workers. I thought that was really, really shocking. But of course, informality makes it very difficult to raise more money for health through taxation. And of course, the focus of this presentation and this session and this whole week, aging. And so I included this slide. This is just one of the projections from the UN of the share of the number of people over age 65 globally, which is expected to increase from about 7 to 8% now to around 25% by the end of the century. And so the question is, why does that matter? Why does that matter for raising money for health? And so for me, I think the best way to think about this is looking at, well, how does taxation vary by age? So this is a figure. I asked for this microphone so I could run around and point at things. So I'll do that. So, and maybe I'll run to the other side too if there's time. So this is data from Austria on taxation per person by age. So we have 5-year age groups on the bottom, and the vertical axis is euros per person. And so this is 3 types of taxes. We have in green, taxes on goods and services, in blue, social contributions, and in red, taxes on income, profits, and capital gains. So I'll start with taxes on goods and services, so the green. So this, as you can see, it's pretty flat over the life course per person. Children consume a little bit less, not a lot less, but a little bit less than adults. But generally speaking, there's not a lot of variation in consumption per person by age. I'll run to the other side so I don't leave you guys alone. Although this is much further than I realized. I should have practiced this once. I don't know if I'll come back. So in blue, this is social contributions, and this follows the pattern you would expect. So children don't work a lot, right? There's no social contributions for children. And then as people join the labor market, this starts to increase and increase and increase. And then around the late 50s, it starts to decrease, and then people retire, and there's not so much social contributions, because this is coming from employees and employers. In red, taxes on income, again, children, they don't earn anything. They consume, but they do not earn. And you see, again, about the same age, and this is using survey data, so this is not perfect, but you see income kind of increases along with income taxes, rather, increase along with social contributions. But then when social contributions fall, income taxes continue to increase and then fall more slowly. And this is because at older ages, in a high-income country like Austria, people have other forms of income than just work. And so this is more some dis-saving. This is assets, really. And so what we do is, maybe I will run back to the other side just so to keep everyone paying attention. So what we do is we can look and say, okay, the age mix of the population will change over time. But what happens if the way that we raise money for healthcare stays the same forever? And so that's what we do. Oh yeah, here, social contributions fall. I said that already. So what happens if the way that we raise money for health stays the same forever, but the age mix of the population changes? And so to illustrate this, we have this simulator. It's called the PASH simulator, which stands for Population Aging Sustainability, Health System Sustainability, Health System Financing Sustainability. I made it, and even I have to think about the acronym. That's why we use the name PASH instead. So this is available online. We did this with the WHO Kobe Center. And what it does is it allows you to take those tax data and health spending by age data. Imagine they stay the same forever and only change the age mix of the population. And then to see, well, what would happen? What would happen to revenue generation? What would happen to spending? And so this is here for Germany, just as an example. We make an assumption that in the base year, 2024 in this case, expenditures equal revenues. This is just meant to be illustrative. And then we see how the age mix changes things. And what you see is that, okay, the population in Germany will age, health spending in red will increase, but revenues will fall as well, because in a country like Germany, about 3/4 of public spending on health is coming from social contributions, and the labor market will shrink, and this will mean that per person, fewer revenues are generated. So in a country like Germany, throughout this forecast period, as you can see here, it's very small, but about 45% of this financing gap between expenditures and revenues is due to revenues. So if you only look at expenditures thinking about sustainability and you think, okay, spending is going up, this is a problem, you don't get the full picture. You really need to understand what's happening to revenues. And in some countries, revenues can really be affected by aging. Okay, but why does it matter? Obviously, it matters for having sufficient stable resources for health. But also, I think if you really think about it, you have this financing gap in the future. If people continue to use health services in the same way as they do now, then somebody's going to have to pay for that, and most likely that will be out of pocket. People will make direct payments out of pocket, or countries will increase user charges. And so what we've done is we've taken those simulations of expenditures and revenues, and we've used a combination of national health accounts data and household budget survey data, and we've estimated how much would the average household have to increase their out-of-pocket payments to fill the financing gap. And so we've done this here for 5 countries in Europe: Slovakia, Slovenia, Spain, Italy, and Bulgaria. And you can see, I'll run over to the other side. I feel like I've spent a lot of time over here. Slovakia and Slovenia, 2 countries that have very high reliance historically on social contributions, relatively low out-of-pocket spending currently, but by the end of the forecast period in 2060, the average household would have to spend about 2.6 times as much out-of-pocket to fill that financing gap. In a country like Bulgaria, also very heavily reliant, not to the same extent, but very heavily reliant on social contributions. But out-of-pocket spending is already very high, and so it's about the average household would have to spend about 30 to 35% more out-of-pocket to fill the gap. Now, what happens, of course, if these households are spending more out-of-pocket? Well, there's a risk that people will experience more catastrophic and impoverishing spending. And so what we do is we take these multipliers and we apply them to our household data, and we estimate the incidence of catastrophic spending due to the people spending more out-of-pocket to fill the financing gap. So here we have in light blue, this is historical data of catastrophic spending. And in dark blue, this is our simulated estimate of catastrophic spending if people spend more out-of-pocket to fill the aging-related financing gap. And you see these big changes. So this is sorted by absolute changes. So Slovakia has the biggest absolute change. Spain, a country that is reliant on general taxation to finance healthcare, so not very much social contributions, only a little bit for some public sector employees. Generally speaking, you can see that there's big increases, especially in countries like Slovakia, Bulgaria, Slovenia, a large increase in relative terms. But there's this. The idea here is to try and draw this link between financial sustainability and aging and progress towards universal health coverage. So 2 policy solutions. So what to do about this? And then this is my last stop. 1 minute. Perfect. Okay. So the first thing is to diversify the revenue base. So a lot of countries in Europe
including Slovenia, for example. So Slovenia historically had the largest reliance in Europe on social contributions to pay for healthcare. Since COVID, they have had more general tax transfers, and actually they've been formalizing this a lot more, and this helps to create more stability. So if you see a country like Spain, a country like Australia, the UK, countries that rely on general taxation with a broad mix of taxes see much more stability in their revenues as the population ages than countries that rely heavily on social contributions. I also was thinking, although this is maybe a risky thing to raise with my 30 seconds remaining, that we think a lot about these systems and raising revenues from labor. But if we really look at things like the national transfer accounts, we see that especially in high-income countries, the wealth exists much more with older households, right? Labor is not the future of wealth production, and I think that if we wanted to consider where can we generate more revenues from, there's a great potential, even though not politically viable in many settings, to look at wealth taxes as one potential option. The second point, and then I'm done, maybe, yes, is designing protective coverage policies. So I think no matter what, there will be challenges for countries, for health systems, as the population ages. And so it's very important to have protective mechanisms in place to ensure that any increases in out-of-pocket spending will not fall disproportionately on those who have the highest risk of catastrophic spending. And so we did a simulation in the case of Bulgaria, and we pretended as if Bulgaria had an income-related cap on prescription out-of-pocket payments, prescription user charges. And we were able to show that you could actually redistribute out-of-pocket spending reasonably well at very low cost, about 82 euros per capita in the final year of the projection, 2060, and reduce out-of-pocket spending even in spite of this age-related gap. So I think that if you're going to have these aging-related financing gaps, making sure that the most vulnerable are protected is crucial. And that's it in my very short time. Thank you for your attention.
Thank you, John, for actually walking us through what we see in Europe, where many of the societies there are aging. So can I trouble you right now? Usually with the way things work, we get the panelists to start speaking first and then you ask questions. But now we're going to ask you questions. So if you could scan the screen, I'm also just going to toggle over to Menti. Oh, we're controlling it from the back. Fantastic. Start the presentation. Oh, that's great. That's me. I'm using my third hand to control the screen. Okay, fantastic. So maybe we can, okay, should I do it then? Okay, great. Next slide. So if you can scan, if you didn't manage to scan it just now is a good time for you to scan it. We have a good turnout here, so do participate. We want to hear from you first before we, get the panelists to share what they're thinking. So whatever you say might influence what they would talk about. I'm not sure, maybe. Okay, next slide. So hopefully you're in. You still have an opportunity to join later on. Tell us where you're joining from. You can either say the geographical place, the country, or even the society that you're working with, the industry that you're working with. Tell us where you're joining from. So, no? Are we able? Okay. Wow, we have quite a few people from Spain, John. So, and Catalonia, yes. Singapore in the crowd. Thailand, India, Philippines, private hospitals, from HTA, from the UK, from Indonesia, Japan. Very, very nice. So yes, future changes of health financing. Thai NHSO, hello, welcome. Okay, good. We're going to move on to the next question. All right, in one word, what is the biggest health financing challenge your country faces in an aging society? Or you think? What do you feel is the biggest challenge? If you do 2 words, I'll forgive you. 3 words, I'm fine, but 1 word. Money, so broken health systems, so sustainability, inefficient, providing FRP, inefficiency, again, pension, fragmentation, interesting. Sustainability is popping up quite strongly here. Yeah. Money, so insufficient money, insufficient insufficient sustainability, very interesting. Okay, moving on to the next question. So which area poses the greatest strain in your country's health financing sustainability? Since many of you mentioned that sustainability is the biggest challenge, I read your mind. So I had this question there. And if you're not sure, pick something. And it may be a multiple factors pulling in together, but what do you think is the greatest strain? And I think our panelists will be able to address some of this and walk us through some of it. Some of us think it's revenue raising. Some of us think it's long-term care financing. Some of them are not exactly independent. They could be part of the process as well, right? Benefit package design. Thanks for those who put hearts. Appreciate them. Okay, interesting. Yes, there's a lot of hearts now after I mentioned that. Thanks for the validation. It helps. Okay, wanted to ask you now, how prepared is your country's health financing system for demographic shifts such as aging? So do you think it's not prepared? Do you think they're very prepared? We hope to see more countries feeling that they're very prepared. Yep, but we kind of expected that many of you would feel that it is not. I think the plenary this morning sort of highlighted that perhaps maybe we need to be more careful with the next steps so that we become more sustainable in the future. Yeah, looks like, we're not exactly, we don't feel too good about where we are right now. All right. Yeah, many of you, so about more than 80 of you have shared that, we are averaging around 2.2 out of a scale of 10. That's not quite, but hopefully we'll become more prepared after PMAC 2026. Okay, so we're just going to leave this for now. You can start keying in the questions that you may have. And this would be an opportune time for us to introduce the panel. But before that, I would call upon my colleague again. Aki, would you want to come back on board to share a little bit more about what the panel is to expect?
Yeah, so we're going to move on to the panel discussion now. So we're going to call on the panel for the discussion. And so during the panel, you are also able to provide your questions so that we're going to identify some relevant question. And also, we're going to take some additional questions from the microphone over the floor. But please do put in your questions so that we can identify good question we can ask to the panel later. So let me introduce distinguished panelists don't join in this session. We have 5 panelists. So first of all, the Professor Ayako Honda. She's a professor in the Hitotsubashi University, Japan. So she will share the Japanese experience on the health financing transition in aging populations. And then second is Dr. Cynthia Chen. She's assistant professor from NUS, Singapore. So that she used to share the Singapore experience. And then Professor Suman Kun, professor from the university, also Seoul National University from Korea. So she also shared the Korean experience. And then we have Dr. Samrit Smolon to Sobs. Sorry, Sanlom Sangwat. So he's assistant professor from Makido University. So he will share the experience from Thailand, Thai experience. And then finally, our dear Luis. So he's an expert on the health financing, and now heading the division of the health system and service delivery department of the WHO Western Pacific region. So welcome all panelists to the floor. So we're going to have a discussion on this topic. Okay, so thank you for joining the panel. So this panel, we're going to showcase some of the country examples and some challenges that we face from the high-income countries' perspective, and of course, country from middle to high-income countries, these transitional countries. That is the main focus, and we're going to have more other agenda after the panel discussion. So first of all, I'd like to ask a question to Professor Ayako. The question is, in Japan now, the Japan's health expenditure is growing up and also facing the challenges of how we maintain the health expenditure. So the Japan also tried to reduce the health expenditure by way that they have several ways that they address the cost control or the out-pocket payment ratio. So the experience from Japan, how the recent strategy that the Japan adopted to effectively manage the health costs, and also where this concern about the fairness and also political pressure to also challenges limit the dispositive impacts of the control in the future.
Thank you. The Japan now has experienced demographic changes, but also labor market changes in the last 20 years. And you might have heard from the other sessions, but the over 65 age group accounting for about 30% of the total Japanese population in 2023. But also there is increasing reliance on precarious employment due to economic stagnation. These societal changes not only increasing the demand for healthcare services, but also there is an increase in income-related health inequalities. Recent studies pointing out that there is a growing concentration of poor health status in low-income individuals. Luckily, horizontal inequity in healthcare utilization in Japan has been relatively low after adjusting for healthcare need over the past 20 years, partly due to residence-based health insurance plan coverage for precarious workers and also reduced co-payments for elderly population. However, as you might have aware, responding to the impact of societal changes on the sustainability of universal SHI system in Japan, and also ensuring equitable access to healthcare services are important items on the policy agenda in Japan. So in order to address challenges to sustainable financing of the health system, currently the government is trying to ensure additional financing resources available through increasing out-of-pocket payments. For example, increases in the co-payment rates for older adults according to their ability to pay was introduced in 2022. And also there is a proposed increase in the monthly ceiling for co-payments when accessing healthcare services. There has been also a discussion around proposed exclusion of over-the-counter equivalent prescription drugs from SHI coverage. So as you would imagine, these measures have raised some concern about equity in financing and access to healthcare services. In fact, recent analysis suggests that out-of-pocket payments for health can increase income inequality, particularly among the over 75 age group. There has been some discussions and debates on increasing or decreasing even the social health insurance contributions and or consumption tax as an additional sources of health system financing in Japan. In fact, social health insurance contribution rates are not explicitly adjusted for ability to pay under mandatory health insurance system in Japan. Although further analysis is required, recent research or analysis on the redistributive effect of the financing health system in Japan indicates that there has been some potential for insurance contributions in some types of plans under mandatory health insurance in Japan to increase income inequality, which also suggests suggesting the need to review the structure of contributions to the social health insurance system, potentially adjust contribution rates based on ability to pay, and also remove upper and lower limits on contribution rates. Increase in the consumption tax, which is relatively low in Japan compared to other similar settings, is a policy option as mobilizing additional resources for financing in health. But this requires political will to implement. The government is also undertaking some measures to improve efficiency in service delivery. These measures include functional differentiation of hospitals and hospital beds and adjusting payment rates according to the function. And also promoting the use of digital health, including the use of electronic medical records, and also promoting home-based care in community health system. They have recently introduced prescription refills to reduce unnecessary outpatient visits. These policy measures, although they are very important, often face implementation challenges as they require changes to multiple dimensions of the health system. And also, these measures, it is really important to ensure service delivery quality as well as improving the efficiency. So I will stop here and then.
Thank you very much. Yeah, so in Japan, that there is no other way to find other resources to do that. So the digital health is one of the potential solutions, particularly digital transformation to improve the efficiency of the health services. Yeah, thank you very much, Ayako. So next question is Dr. Sincere. So that the Singapore that's also rising the health insurance due to the aging populations. So that is a big challenges in this country as well. So and also we know that the Singapore is a sort of mixed health insurance system with both the private and public insurance. So what is the way that the strategic purchasing mechanism to control the increase of the health insurance in this kind of mixed method, mixed system in the health insurance?
Thank you so much. So in terms of purchasing levers, I'll just cover 3 points. For the first point is centralized purchasing. So in the past, in our public health institution, the different healthcare clusters actually does their own purchasing. There's a consolidation to do a strategic purchasing from all the public healthcare clusters. And this helps with central procurement and also have economies of scale to try to drive down cost and also maximize efficiency. The second is value-based purchasing. This is where the Agency for Care Effectiveness in Singapore is a National Health Technology Assessment and Clinical Guidelines Agency, that they do a lot of good work behind the scenes to try to conduct assessment that are of clinical benefits and also cost-effective. So what they do is they negotiate prices with vendors on drugs and also some medical devices. And this ensures that our public funds, that because of population aging has a lot of other constraints, the funds are actually best used to balance out the value that we are getting from the treatment. Take an example. When there is a move from biologics to biosimilars, what they did was they subsidized a lot more of the biosimilars. And then they realized that after a year, some of the biosimilars, the uptake rate is more than 90%. So they kind of use subsidy to highlight what are some of the more cost-effective. That brings me to my next point about subsidies for treatment and also on cancer drug, where they put up a cancer drug list. So what they have done is, in the past, when it comes to cancer rates and cancer prices, so we have a national health insurance, which is the MediShield Life, that has a cap of, say, $3,000 a month for all cancer drugs. Then the private insurer has a as charged payment. So whatever that the vendors charge, the private insurer will cover. So that's the as charged. And what they realized is because of this, the drug companies had no incentives to lower prices because the insurance would pay for it. So they went in and then they had the cancer drug list to have specific cancer drugs for specific pricing. And then there are different rates of subsidy given the type of cancer drugs. And this change allows us to have a better control about the prices of cancer treatment in Singapore, to negotiate lower pricing. Because what they realized is because of our generous health insurance, we are actually paying much higher prices for the same treatment compared to Australia or the UK. So in doing this, it sends a signal where they subsidize based on what the treatment is and how valuable that treatment is. So for cancer drugs that are not on the list, then there's no subsidy and there is also no way you can use insurance to pay for it. Yeah, so that kind of sends some strong signals. And every 3 years, or quite regularly, the government does a review to put in the more cost-effective treatment into this. So the government on the supply side is doing a lot of background work to try to rein in on the cost.
Yeah, thank you very much. It's always challenging how we negotiate the price of the drugs and also health services, particularly it's a mixed financing the schemes in the countries. Okay, thank you very much for the. So next question, I'm going to like to ask the Professor Suman Kun. So you are expert on health financing. in Asia and other countries. And not only the national health financing of the services, but also the long-term care. That's also part of the services we need to address in the aging population. So I'd like to hear your guidance on the financing reform is more effective, how we can promote the streamlined flow of the health services, but also long-term healthcare services and social care. How we can frame this long-term care as part of the financing reform in Korea and also other neighboring countries. And also like to hear from you is what kind of finance model we need to address in the aging society, especially it's more expanding the informal sector because the retirement age increasing.
Okay, thank you. I'll provide some comments based on the major pillars of healthcare financing. First, resource generation, I fully agree with John that we should diversify the funding sources. I can give you two more concrete examples. The first, like also mentioned by Ayako, is consumption tax. There's an example of like earmarked consumption tax channeled into healthcare financing system in Ghana. Okay, they use 1.5% of consumption tax channeled into the health insurance system. You know, in theory, there is the weakest point of consumption tax is regressivity, as you know. But in reality, the consumption tax is not as regressive as you're worried about because consumption pattern of high income and low income people are different. Okay, so that can be one important source we can consider. Next source is that how about the contribution base? Because majority of the mandatory insurance contribution is based on wage, so that so-called payroll kind of tax. But we can expand the base for contribution settings. So for example, in Korea, I pay two types of contribution. Every month is automatic deduction. My university charges contribution based on my salary, but I also get, got checks from the insurance agency. That contribution is based on my non-wage because I have like investment income, other types of income, not from my employment. So if you expand the base of contribution, it'll be an alternative source. But they are all not just a technical issue, a lot of political economy issue. In terms of pooling, there's a consensus that we should, one bigger pool is more efficient and equitable than fragmented multiple pools. And the efficiency and equity of a single bigger pool is even more important in an era of population aging because many old people, they tend to live in rural areas. So if you have a small pools for covering each geographic areas, it cannot be sustainable. Okay? So as I said, we should have a bigger pool in healthcare financing. How about long-term care? Okay? I'm a strong advocate of universal health and care coverage, I say UHCC, because in a conventional paradigm, we just target health as a final outcome. But for older people, process, NCD management, or care, process is also very important. There are a lot of vicious, also virtuous circle between healthcare financing and long-term care financing. Then the question is, do we, in terms of pooling aspect, do we want to have a separate pooling for health and long-term care or one big pool covering both? Many health long-term care insurance countries, Germany, Japan, Korea, we used separate pools, okay? Separate pool, separate insurance for healthcare, separate insurance for long-term care. The basic rationale is that we wanted to demedicalize care by separating the two pools. But there is a cost because coordination failure between these two pools. So there's a big challenge in terms of pooling and in terms of governance issues. Okay, purchasing. First, it's the benefit packages. Okay, we should definitely expand the benefit package to responding to the needs of the older people. First, simple thing is the medicines, NCD management. Traditionally, our health insurance or financing started with covering the catastrophic inpatient care. But in this era of population aging, that doesn't work. We should definitely cover NCDs, and then medicines is the key. Okay? Because without medicines, how can you have NCD management? But there are different types of medicines, like cancer medicines, as colleague mentioned. It's so expensive. Even in Korea, we are struggling with the health technology assessment benefit packages for anti-cancer medicines because growing number of anti-cancer medicines are precision medicines. Even a single big payer does not have a bargaining power with so many precision medicines. It's a big, big challenge. Another one is a payment mechanism. We know that we should move away from fee-for-service. How can you have a good primary health care when you have a fee-for-service? So we should definitely adopt some kind of risk-adjusted capitation method for the strengthen primary health care. But I would like to question, strengthening PHC, is it our final goal? Of course not. Our final goal is integrated health and care system, integrated care system, primary care or primary care team, acute care, post-acute care, even long-term care. In that case, maybe capitation may not be enough. We need some kind of more innovative, more inclusive payment mechanism like bundle pay or episode-based care. Sorry, but one final thing. And also I found in many countries in the region, there's a governance issues in this integrated care system. Because many of those primary health care, especially public sector primary health care, is at the hands of local governments. Whereas in the acute care, at the hands of more centralized purchasing through insurance mechanism. So there's a huge misalignment between local government initiated primary health care and centralized purchase through insurance mechanism, that's healthcare. Not to mention the harmonization between healthcare and long-term care. I think I should stop.
Thank you very much. So we need to also adjust all the different layers of the health financing from revenue raising, pooling, purchasing in the transition of the demography. And of course, the centralized is important, but also in terms of service delivery, we also need to address how we strengthen the local governments, who is the one to deliver the services. So that's the kind of matching the centralized and the decentralization strategies. So the second, next question to going to the Dr. Samrit. So the Thailand is one of the champion USA agenda, not only the service delivery and curative care, but also health promotion and prevention, which is one of the key area in the aging population. How we address the NCD, not only treatment, but also how we prevent and promote the health NCD agenda. So that we'd like to hear from you that how the Thailand address this agenda, not only the service delivery perspective, but also financing perspective to promote the health promotion prevention as part of the USA agenda. Thank you.
Okay, thank you for your question. Before I answer to the question, I would like to share a few context of Thailand, let you know a little bit about Thailand. Thailand, we already achieved universal health coverage in 2002 by 3 main public health insurance schemes. The first one is for civil servants and their dependents. The second one is for private formal sector, like for the social health insurance scheme. And the third one, which is the biggest scheme in Thailand, is for all the rest of the population. That is the universal coverage scheme. All the 3 schemes are managed by different organizations. So they have their own governing body. So they can set their benefit package, set their payment method, and so on. So that is one. After the introduction of the UC scheme in 2002, we have observed that there have substantially improvement in access to needed health service for our Thai population. This partly also contributed by the well-establishment of the basic health infrastructure in Thailand. Actually, for the district health system, right? We have the district hospital is the major hub of service provision for the UC scheme, together with the health center, right, as the state-like unit. For the health prevention and promotion, I think we can have 3 layers of the program. The first one is at the individual level, right? Health promotion and prevention service are included in the benefit package of the UC scheme and providing free to all Thai, regardless of their health insurance coverage, because the other 2 schemes are not covered for health prevention and promotion. They cover just only for the quality care, right? At the community level, we also have the community health fund. This is a matching fund between the National Health Security Office for the UC scheme with the local governments, and it aims to empower the local governments and also for the local community to tackle with their own health problem, right? And the fund is managed by the local committee. And the third layer is we have the Thai Health Foundation. So this is the Thai Health receive the annual budget approximately around 120 billion baht from the government, from the excise tax on tobacco and alcohol. And it aims to inspire, motivate, coordinate, and empower individual and all related sectors to enhance their health promoting capability, right? As well as healthy society and environment to support the health promotion movement in Thailand. So these are the three layers of the health promotion and prevention in Thailand, mainly not only under the UC scheme, but also movement by the local community and also by the Thai Health Foundation. So if you look at the primary healthcare approach framework, so I think that we can manage it comprehensively, starting from the personal and population health service, empowerment of the community, and also multi-sectoral policy and action. Right? So during for the aging population, what financing change that are needed in order to cope with the system? I think we focus more on about the improving efficiency of the revenue or resource that we have in hand. Right? The first thing that I think we need to change is to harmonize the three public health insurance scheme because of the fragmentation of the current scheme that is needed, right? The second one is to allocate of the health budget in order to support for the healthy aging society, like for example, for the lifestyle behavior modification to prevent for the decline of the intrinsic capacity of older people, and also to support or strengthen for the palliative care and end-of-life care. And the last one is to introduce the value-based payment mechanism in order to support the integrated people-centered health service to cope with the chronic condition, improve the effective coverage of care. So that is, thank you.
Thank you very much. So not only the individual-based prevention, but also Thai has a specific scheme to promote this population-based financing, and also that's channeled to the community-based activity. That's the kind of mechanism that Thai set up the beginning of the UC scheme started. So that's a very good example that we also learn on this. So they let me going back to the Luis, the WHO. So WHO promote primary health care, and the Professor Kuman said also that important is how we integrate services and people-centered services, and not only the primary care level, but also connect referral system and connect to the other acute cares and age and community care. And also we learned a lot from high-income countries case. That's also important to learn. But how the middle-income countries kind of get the inspiration to adapt this into the country context in the future, because we cannot simply copy and paste now, but also it's going to be a longer-term planning and the changes we need to address. Thank you.
Thanks, Akito. Good morning, everyone. Let me start first optimistic with an optimistic point. From this part of the world, I think the governments are waking up, and for some areas, we struggle to find to create the policy space, the attention of government. But on that, it's not the case. We have attention of government and we have interest of government, and I would even say some governments are even panicking about the challenge that is coming. And another good point is there is a lot of goodwill to share, and from high-income countries of the region and from others to explain the journey. And actually, one of our experience with supporting some countries in the Western Pacific region is that there is a lot to learn from high-income countries and a lot to avoid. A lot of don't do what we did. And I think that's probably even more important. Let me share a few things. First, building on John's presentation, if you look at the size of governments in this part of the world, now the revenues out of GDP, and we compare with the countries that John was sharing, we are half. So we have a small government, so small pipes. And this, we could discuss for hours, but this is a result of some sort of societal choice of governments to keep governments small and not to tax we have at least 4 countries in my region have less than 12% out of GDP on taxation. You cannot play a lot with the size of this cake. The second point is the informality path. Now, we all hope that we would be Korea. We hope that with the economic growth and the moving from middle income to high income country, we would reduce formality. That's not the case. And you probably, our Thai colleagues know the middle income trap which is quite common in other regions, in other countries also. So in this context, at some point we will need to face very difficult political questions. We cannot play with this cake, and we cannot replicate the path of Japan and Korea because we don't have the same. So we are in uncharted waters. We really need to find solutions that we might not be able to learn from high-income countries. And I think you John, pointed already some ideas, and actually you also, Sunman, on mix of revenues, but sooner or later will mean more revenues. And societally speaking, we need to start being frank to our politicians and power dynamics. That's the crude reality if we don't want to have an extremely unfair system to fund it. Good. Let's put some good points also. I think interestingly to learn from high-income countries is governance arrangements. I think listening to how Korea, how the Netherlands, how Germany, how Japan, the role of municipalities, there is a lot to learn from it, and the pros and the cons and the advantages of pulling it all responsibilities and difficult questions like care coordination. No, we give the responsibility to clinicians, we bring social sectors, are they more suitable? But that's difficult questions that listening and looking at high-income countries can help on that. Let me add a couple of points. We like a lot in this part of the world find demand-side solutions. No, an insurer with cash will buy what is in the market. No, but honestly, this doesn't work for everything. This works for capitals. This works for if the supply side is there. But question to all: is the supply side there? And on long-term care, we need to invent this supply. We are relying on families and formal workers, but there is change culturally that this is disappearing. So who is going to provide? These categories doesn't exist. We need to invent them. And let me tell you some problem that keep me awake at night is the circular problem of health workforce shortages on health, but will be also for long-term care, which is we have shortages, everybody knows, and maldistributions in many areas isolated. But then they say, let's produce more. And then we produce more. Most of the countries produce more health workers than ever in Europe and here. But then it comes, they cannot be absorbed the system. Why? Because the wage bill cannot accommodate that. So then it's a fiscal. And then we go back to the original question. Do we want to pay taxes in order to have this health workforce in place? And this is a circular problem that I am observing in many places. Last one, sorry, I'm overshooting. Let's look at the point of Sunman on provider payment mechanisms. Currently, in most countries in Asia, our payment mechanisms are based on episodic and making facilities to compete against each other for revenues. All the features that we need for long-term care, it's the opposite logic. So we really need a deep purchasing discussion to address that. Thanks, Akito.
Thank you very much, Luis. And you see that we are matching the color. And the orange is health financing protection color. And ADB and the WHO is working together to facilitate the knowledge learning. Thank you for joining me. So thank you for the discussion. So we have around 40 minutes for the interactive discussion with the audience. We have the time for collecting question and answers from the floor, but also we have some questions from the Mentimeter. So let us start with the Mentimeter question. Keisha, can you also come here so that we can identify key question we like to ask to the panel? Sorry, I can't hear. Okay, it's this one. So it is the one we like to start. Okay. So the first question from the audience: the social services and the community care tend to rely on the informal workers and also services that helps coaching, care goal discussions, and care navigations. They're hard to change. And how do we finance these equitably? Anyone wanted to take this question? Maybe. You want to take it? Yeah, okay.
Yeah, one way to tackle this problem is socialize these services, of course. But that's, for example, one role of long-term care financing and long-term care insurance. Okay? And also, but still, in the case of long-term care insurance or financing, formalized system, we don't deny the role of informal caregivers or family caregivers or other currently unpaid job. So there can be potentially like a lump sum subsidy, cash benefits for those currently unpaid areas of work. But I'm not sure whether I'm responding to that.
While waiting for Akito, let me add one word. It's health workforce challenges takes 10 years to fix. It's not health financing is faster. But you have to fix the problems today, you should have thought 10 years ago. Then the problem would be, but the problem cannot wait, no? So built on what it could be in our policy tool. And some countries have decided, okay, we recognize the informal sector there. So can we subsidize the premiums for them to pay, to be covered in a social security scheme? By subsidizing that, and you start formalizing the informal sector while you prepare the workforce that you will need in the long term.
Thank you very much. So we're going to take a few more questions. So Keisha, can you identify the question and maybe lead out?
Sure.
Yeah.
Okay, thanks, Aki. So one more question from Menti. How do you merge public social insurance and national health insurance schemes to holistically cover the needs of elderly people? Tough one.
That's someone.
It's your
First,
question.
the definition issues. I know that many countries, like in Africa, social insurance means formal sector workers, and the national insurance is informal. Is it correct? First, clarify the definition. Who asked this question? Yeah, because some countries like Korea, Japan, national insurance is self-employed small insurance, small firm, and Korea is the national insurance means everything. So other countries, social insurance means holistic insurance.
Probably we can see this is national health insurance, not just the social.
But it's a merged public social insurance and national health insurance. So does it even cover the needs? Well, so in the case of, you can see the examples of the Philippines, Korea, Indonesia, that we started with multiple schemes and merged them all into one. So that is one thing. But as I said, it's not a technical issue. Huge, political economy, as you can expect. The formal sector workers scheme, formal sector workers are against the merge. So you should get over these big oppositions. And then holistically cover the needs of all elderly people. it's more of a benefit package decisions. So my user suggestion is that you can first, whether insurance tax scheme, it's based on the context. But if you already have an insurance scheme like those countries, many countries in the region, then you can start by extending the benefit package of existing insurance scheme to cover the care needs. So that can be a logical step to cover the needs of all the people in terms of care. But the question is not very clear to me.
Anyone wanted to answer a question or the next question?
No, I mean, the only thing I would say on that question, although I share Sunman's confusion, is more of a lesson of what to do, but also what not to do. So Kazakhstan has a similar experience where they have a system, a state benefits package for everyone, and a social health insurance system for formalized workers. And they've for many years talked about trying to merge these together. And the one step that they've taken, or that the one characteristic that enables this to some extent, is that it's the same entity that's purchasing on behalf of both benefits packages, but they really struggle. They have overlapping benefits, so sometimes they don't know provider is billing to, it should be paid by the state benefits package. This is a terrible microphone. Maybe this one's better. Yes, much better. They don't know if they should be, because the tariffs are different, they don't know if it should be coming from the state benefits package or from the social health insurance scheme. So there ends up being a lot of confusion. And I think that even though politically they do see this idea that they will eventually merge them into one, it becomes very difficult. And in part because of Luis's nice point earlier about the size of the cake and the difficulties politically in trying to convince a small minority that's contributing to a system that they should have the same benefits as everyone else. And I think these become very difficult political challenges.
So we're going to take one more question from Menti and then moving to the question from the floor. So which one? Standing already? Okay. So would you like to start? Yeah.
Well,
Please.
I'm obviously not very capable with tech, so I'm going to just speak personally. But it did actually relate to a question that I did notice that was up on Menti. There's a lot of discussion, obviously, about integration of care across the continuum. That was in the last session, and there's discussion, at least intermittently here, about capitation and you changing the payment structure so that you're capitating, and that would solve a lot of the problems with some of the dysfunction in the current system. The question that I don't hear a lot about, and I'd love to hear any comments about, is the issue. By the way, I'm David Matcher. I'm a physician and a health services researcher at Duke in US and at Duke in the US. And I've been doing a lot of work with Healthier SG, which is the Singapore system for restructuring primary care to be more integrated as part of the entire healthcare continuum, which includes community care. But the one issue that I keep wrestling with is the issue of governance, which is to say, it sounds like a good idea that we're going to capitate and then we're going to let this money flow down and then we're going to have special amounts that are going to be for innovation and for value-based services. And if you're providing value-based services, you get a little more, that kind of stuff. But there's very little discussion about how this actually happens in the real world setting. I mean, governance, this is a governance structure that's quite complex, but that doesn't sound like that discussion has really surfaced as much as, well, how do we pay for it? That's the sort of a macro question. Do you have any comments about this?
Okay, which one would like to take the question?
Thanks for the question. Let me reflect on what I have been observing in some parts. There is a challenge that also in Europe they have not been able to fix, which is how to put together to work hospitals, primary health care, and long-term care. In China, they have started to, I would say 5-6 years ago, to start paying the networks. So the you change the unit of payment rather than individual facility. You pay the network that has to be in charge of a certain number of population, including long-term care. So basically, you challenge the incentives. Right now, in many countries in my region, is everyone competes for revenues, both primary healthcare and hospitals, between hospitals. And there is zero incentives to collaborate, to share, and to make the patient navigate the system. But one of the brave, I would say, feature of this idea in China is when you put it all together into a single scheme, at least you remove the incentives of competing among each other, and actually you introduce an implicit incentives to shift care what is less expensive. If they can retain the savings that they generate, no? The payment mechanism, capitation alone, and I think Sulman has already mentioned, is not enough, and it will not be enough. But I think that a dynamic purchaser normally keeps adds on the contracts, and there is a blended for targets, but also there is few things that you will never capture on the core of the contract that you can keep adding. There is no wonderful one shot that will fix it everything, but it's to keep it these dynamisms of adjustment, and China is trying at least.
I mean, can I add a bit to David's? I mean, I fully agree with you that the governance is the key. Two examples. There's a big governance between health and social sector, because in the majority of countries in the region, health ministry and social ministry are different, with the exception of Japan and Korea. Recently, Vietnam, they eliminate Molisa, and that will be one ministry. But there's after I have so many experience of policy discussions, big different mindset, and they are willing to discuss on this. And long social care falls in the boundary between health ministry and social ministry. But go further, even in the health sector, as I briefly mentioned in my comments, there's a big governance issue between primary healthcare, because majority of the primary healthcare in many low and middle income countries are at the hands of local governments. Whereas acute care hospitals are at upper level of government, even payment method is a bit different. Like PMJ, Indian PMJ, a lot of successes, but still like a governance issues, because primary healthcare is provided basically free of service at the health and wellness centers in the government, whereas PMJ mainly covers the inpatient care. So there's a kind of a governance alignment issues between primary care and advanced care, and also health sector and social sector that critically affects the integration of health and social care services. In the British system, as you know, there's a primary care team. They commission both health and social care. But unfortunately, we don't, in Asia, I've rarely seen that strong capacity, the primary care team existence. I mean, Luis mentioned that there's some pilot alliance in China, but also last week I got some kind of discussions on that. He said and she said about the successes and failures of those medical alliance pilots.
Thank you very much. So we're going to take one more question from the mentee and then open the floor. So one more.
One last question from mentee. How can health financing be more sensitive to demographic variables such as fertility, aging, and migration? And we're wondering whether we can hear from our country experts as well.
Yeah. So the Cynthia Ayako, would you like to respond to this question? Maybe Cynthia, if you can.
So for Singapore, how we have done it is through a mixed scheme of responsibility. The government comes in to heavily subsidize the public healthcare services. And then there's this very strong layer of individual responsibility that is the National Health Insurance MediShield Life. And for us, as when we are all in the working ages, we have this thing called a CPF that part of it would be a MediSave account. So when we work throughout our working life, we would only get 80% of the salary, 20% goes to the CPF. On top of it, the employer tops up 17%. So in total, there's 37% every month that is in this account that we cannot touch other than for specific services. And one of the accounts is MediSave. So year on year, when we are healthy and working, year on year, the MediSave grows. And when we retire, the MediSave accounts can be used to pay, and even throughout life, you can use the MediSave account to pay for public health insurance and some of the public health care. So that allows an individual to use the MediSave account to pay for the healthcare service, while MediShield Life pays for the catastrophic health services that is in the acute care. And then there's also the out-of-pocket and co-payment. So it's a mixed structure that is balanced on government subsidy, individual responsibility, and the co-payment mechanism. And then when older adults, as they age, because in the past, a lot of them are informal workers. So there isn't, a lot of them may, especially females, may not have this CPF scheme. So what happens is the government does some of the top-up, and then it has this mandate where older adults will never lose their insurance even when they cannot pay for it. So basically, it's a national health insurance that covers older adults. I mean, it covers the entire population. But it's through this mixed structure that somewhat seems to work for now. But because the risk pooling mechanism is by age, so premiums would naturally increase as the individual age.
Well, in Japan, perhaps I think my responses might link to the previous questions as well. But I mean, under mandatory health insurance in Japan, we have our system is multiple pooling system, which might be a bit an issue in relation to fragmentation of pooling. But then I think we also have a standardized purchasing mechanisms. Although we have a massive number of pooling, the financing fund pooling mechanisms, but then I mean, the purchasing mechanism is just one standardized mechanism. And then the government is using this. And then the purchasing mechanism, the standard purchasing mechanism is revise the payment schedule 2 years. And then what I'm saying is that the government using these revisions of the payment rates as a governance tool. So in the process of Thank you.
This is pooling, is I think.
But then this is a nice sort of multiple poolers. Can you hear? Okay. So what I'm saying is so in the process of revising the payment schedules, I mean, there is a kind of, at the beginning, there is a kind of strategic planning, what areas in the healthcare services needs to be increased the payment rates and then decrease the payment rates in order to address the issues in relation to the public health priorities in Japan. So I mean, in the process, I mean, although government is trying hard to sort of reflect what's going on in relation to the societal changes so that we can also identify the public health priority areas and then to consider and decrease in the payment rates in order to influence on the healthcare providers' behaviors and also access to healthcare services. So I'm just sort of saying that how best to reflect on the societal changes in relation to demographic changes and other societal changes. I think we have a kind of governance system that can actually reflect the societal changes. I mean, that the issue might be is that, I mean, how effective that the mechanism is working.
Thank you very much. Dr. Samit, maybe if you can also adding from the Thailand perspective on the NCDs, or maybe migration is also one of the topic covered in this topic.
Okay, for NCD, I think this is a major burden of disease in Thailand. Everyone recognize that, but unfortunately, even we provide universal health coverage and enable access to needed health service for our population, actually for those with chronic condition. However, we found that the effective coverage is quite low. For example, for the well control of diabetes and hypertension is not exceeds 30% of our patients. So I think that what we have to do is to redesign our health service delivery system toward the patient integrated patient care, right? Because for those who need continuity of care and coordination of services, otherwise we cannot achieve our target that we would like to improve the effective coverage of our treatment for the chronic condition, right? That's the one. So we try to pilot on the value-based healthcare. Existing is on the process of piloting, right? I also would like to share some questions about the integration of the health and social services, right? In Thailand, according to my experience, I found that the low age or the small age organization are the best place for the integration of service. So I would like to support of the decentralization to the local government. Actually, currently, Thailand, we also try to transfer the primary health center to be under the local government, and also for the long-term care service, we also employ the local government to manage it, because we think that it is the best place that we can integrate both health and social services together. Right? Thank you.
Thank you very much. So now we have around 20 minutes, less than 20. We're going to open the interactive discussion with floor. So we're going to take the question from the microphone, and please state your name and affiliation, and also focus on the questions, not the statement, so that we can take more maximum questions from the floor. And we have around 20 minutes. So if you have any specific question to the speakers or panelists, please also mention with that question to which speaker. Thank you. So would you like to start?
Yeah, so thank you. I'm Paul Ong, the Deputy CEO of the Sao Foundation in Singapore. Listening to the discussion today and also looking at some of the questions actually triggered, quite literally for me, a new kind of thought. And what I wonder in this discussion is that it's not so much about whether you've got capitated bundles or integrated financing systems for health and social care, but rather whether there's actually one aspect of the combined services that are needed, particularly in a time of demographic transition, that we have never got to grips with. Through the entirety of building health systems, till today. And that is actually how you fund preventive health or preventive approaches, actually not just to health, but also to social issues, which become particularly important actually in population aging. So give you a very concrete example of perhaps how we need to sort this area out. Take my teams, when they go up, Cynthia, as you know, at AAC, we've got a certain catchment of older people. The remit from the government is keep them off formal services, do what you can to keep them aging in community. The integrated community care providers platform that's now being built is specifically designed to help civil society and communities to manage increasingly more and more complex elders in the community, away from specialist services, away even from our primary healthcare polyclinics, right? So the interesting thing is this: all of the financing packages are predicated on the idea of somebody arriving, and then when they arrive, they get the services, and then, okay, here's the package, or here's the payment for this person. What my teams are doing, or what the system in Singapore is doing at the moment, is creating the client even before they know they are a client sometimes. And not only that, when you find them, your remit is to keep them away from encountering the formal services. So basically, if you take even some of our complex clients, 80% of what's delivered to these clients is done by civil society, is done in community. The formal services will come into contact with these people about 20% of the time. So about
okay,
7...
Thank you very much for the...
Sorry. So I just wanted to finish up by saying anyway that I just wonder, whether in this particular context, a preventive approach actually to both social issues and social isolation, as well as the health issues, is an aspect essentially of health budgeting that we've never sorted out. How do you
pay for preventive services. I don't think anyone's ever sorted that out. Sorry, thank you.
Maybe Dr. Smith or Ayako, would you like to respond?
I mean, responding to the question itself, but I'm just sort of introducing Japanese case. In Japan, we have medical health insurance. I mean, as Sumon mentioned, I mean, we have a parallel system: medical health, social health insurance, and long-term care social health insurance. And medical health insurance covers the benefit package of the medical health insurance is the social health insurance. Social health insurance covers the medical services. And then apart from but then I mean in Japan, the public health services, including immunizations and prevention health promotion, are directly covered by the government, either the central government or local government. So the prevention health promotion is not part of the benefit. Sorry. I might be picking up the wrong mic. Or I might be using the mic.
But distraction signal from your body.
Sorry. So what I'm saying is that in Japan, I mean, the social health insurance benefit package does not include prevention and healthcare promotion. But then prevention and health promotion, public healthcare services are provided directly by the government or the local government. Whereas long-term care actually includes quite a range of the care. So not only home-based nursing care, but also it provides preventive frail care as well. So perhaps I'm just sort of saying that for the older adults in Japanese case, and then preventive care in relation to population aging, the age of older adults are covered by this long-term social health insurance. And then what I'm saying now is that coordination, because somehow the Suman sort of raised the issue of whether or not to integrate social medical insurance and long-term healthcare insurance, I mean long-term health insurance, but then in the case of Japan, right. So in the case of Japan, integration might be a bit difficult in relation to this, what to be included in benefit package in the medical health insurance and long-term healthcare insurance. But then we do aware the coordination between the medical health the service provided under the medical health insurance and the long-term health insurance. For example, I think we are now trying to coordinate information system between social health insurance and then long-term health insurance, and also trying to sort of incentivize the coordination activities between the two. I don't think I'm sort of directly answering the question, but then just sort of introducing Japanese case.
Sorry, just I want to ask two cents. One is it's happening. It's not. I don't know where Paul you are sitting now. Sorry. Yeah. Just one enabler. I've seen it, so it exists. It's not that that's never happened. One enabler that we have observed in a European country is the information system, meaning if you can have the entire of your population categorized by morbidities and all the health needs, plus the socioeconomic needs, it gives you a tool to facilitate this integration. And if we develop primary healthcare teams where clinicians and social workers are there, is where you can make this happen. We can talk later about how it's paid.
Thank you. So we have around 10 minutes left. So take 3 questions. So if you can have a question briefly so that we can take 3 questions for sure. So Nima, please.
Thank you. Good morning. Nima Askari, Director, APO, Asia Pacific Observatory on Health Systems and Policies. I'm going to ask a question which is a bit way out there, just to see what Sunman and possibly John says. Sunman, what you were saying was that demographical and epidemiological changes are going to be a major cost factor, especially on cancer diseases moving forward, right? One of them. And that's primarily because of the precision medicine costs coming in, where we cannot really negotiate on cost on HTA. Do you see a point where financiers of healthcare need to move into investing and purchasing the manufacturing process in order to contain cost.
Suman, do you want to start?
I mean, because you asked me, my answer is no. My answer is unrealistic. Because a lot of innovative, because R&D in the medicine sector, there's huge, of course, we criticize heavily those pharma industry, but still, if public sector is directly doing manufacturing of those whole, I'm sorry, I'm not positive.
I agree with Suman. I think that, yeah, it's nice to make the pharmaceutical industry the boogeyman, and I totally subscribe to this. But at the same time, there's a lot of risk involved in the development process of new medicines, and I don't think that government wants to take on that risk, even if government is involved. Now, the one little step towards that vision, I think, is that governments could, because ultimately a lot of the initial investment before you start going into trials does come from government funding. And so governments perhaps could do a better job in securing, if this goes to market, then I expect some heavy discounts and make that a conditionality on that. But yeah, actually engaging in the R&D and the manufacturing, I don't see that happening, but I can see, more rebates, more agreements between governments funding research and eventually obtaining heavy discounts. I actually don't agree totally that precision medicine is such a big cost driver in most countries, only because I don't think most countries will cover it. So I think that the reality is that this is an issue for the high-income countries. I mean, we have this issue in Europe. There's the European Commission, the European Commission, the head of health, is very into competition and really wants to incentivize the industry to produce more precision medicine and these types of very expensive treatments that are geared towards the individual based on their exact condition or their genetics. And in reality, I think that this is foolish because most of the countries, even in Europe, can't afford to pay for them. So I think that unless these come down massively in price, it's going to be very small segments of the population, with the exception of like the US, that will actually be paying for them. So
yeah, thank you. So the next question, please.
Thank you for this wonderful session. My name is Shin Hye-ha. I'm working with MSF, also known as Doctors Without Borders. So I have a question that is actually linked a bit to the former question and also the answer that you just gave. In most contexts, the biggest expenditure of health insurance is actually in the purchase of medicines. While there's a lot of discussion on revenue generation and financing models, my impression is that the discussion on cost containment is often missing in a lot of these debates. So is there a way to really have a regional collaboration or a national effort to contain the cost of medicines and to really make that into an agenda of collaboration within the region? And I have a second question, which is a bit not connected to that, but with limited possibility for the public sector to continuously raise money, is there a role that the private sector can play to fill those gaps, but both in terms of the insurance and the service provision without the negative impact it may have on the overall health system?
Thank you very much. The first question, Luis, you can answer. Second question, we're going to go to the next agenda. We're going to have a session to talk about that. Yeah. Later.
Okay, let me be short and undiplomatic. The solutions on access to medicines is never a technical problem. So, to fix the point that you're trying, it's a need of collaboration, and collaboration with some stakeholders that most probably have a big stake and is difficult to address. A lot of tentatives has happened on that domain. We will continue trying to do, but to find this common denominator that makes it happen has been proved quite difficult. Happy to discuss more.
Thank you very much. So the second question we're gonna ask later, but anyone else, one more question is okay? Yeah, okay.
Mr. Pante Chochai Swatana from National Health Security Region 2 in Rowan, Northern of Thailand. My question is, how can Thailand transitional from volume-based fee schedule payment model to a value-based system that prioritizes health outcome over the number of hospital visits, outpatient visits, something like that. And another is how to strategic align the budget from the three public health scheme of national health security, universal health scheme, social security, and civil servant scheme to ensure equitable and access to high value care and address the demographic change health problem.
Thank you very much. So that's a question to Dr. Samrit, if you can answer two questions. Thank you.
Both questions are difficult to answer. For the first one, I think that it depends on the policy view of those who manage the UC scheme, right? Because we try, but anyway, at the moment we try to do some pilot and to do research in order to prove that if we change from the value-based payment to in place of the volume-based, we can get a better health outcome, but that's on the process of the research and development. And for the second one, I think that is the most difficult one because of there are conflict of interest and also the political economy, how to harmonize the three main public health insurance schemes. There are some effort in order to harmonize, but usually based on the technical issue that we can harmonize. But for the financing one, I think I have no answer for that. I think even at the time that there are very strong political power at the time of Thai Rak Thai party, right? The Dr. Thaksin Shinawatra is the powerful people. He's still not able to do it. So I don't have that answer. But what we try to do is to harmonize the benefit package, harmonize the payment method, and so on. Thank you.
Thank you very much. So we need to move on to the next session, but do you have one question? So
Yeah,
briefly, please.
I have a brief question about long-term care. I thought it's very expensive, account for 1% of GDP in most European countries. And you said that the payment system is totally different from usually the competition system that we try to impose, like capitation and DRG or anything like that. What is the difference of long-term care payment? That because it is a big, huge scheme.
Can I respond to 1 minute? Because this is a very typical kind of a question about long-term care financing. There are both equity and efficiency argument for a long-term care financing. First, equity is, we all know. Efficiency argument, first, when there is no long-term care financing available, then there's a lot of increasing number of social admissions, bad luck in acute care hospital, because all the people who can be discharged from hospitals, but they don't want to be discharged, because when they are discharged and to home, they still need care, but the care is not covered by public. So it results in social admissions, bad luck. Second, we often say, well, we have a family value, we have a family caregivers provide care. The question, two questions. Is it really reasonable quality? Are all the people who receive care from my adult child, are they happy? That's a big question we should ask. Are they happy? Are they satisfied with the quality of care provided by adult child? Second, it affects the labor market participation of the caregiver, of the family members, especially women. One of my doctoral students recently finished dissertation showing that double burden of, everywhere in the world, most burden of care on the shoulder of, women. It heavily impacts their labor market exit and even the wage, even when they stay in the labor market. So we have a huge efficiency argument, I think, to have some kind of financing mechanism or system, formal system for long-term care.
So that is the data not captured in the health financing. Yeah. the data, right? That's we need to also think about that. That's an additional element that how we can improve the efficiency of the system. Okay, so thank you very much for the discussion, the panel. So we're going to move on to the next agenda. So you may go back to the seat. So the previous session focusing more on the demographic transition, how we can improve the health finance stability, and we shared a lot of case studies from high-income countries, but also middle-income countries. So next session, we're going to focus more on the current situation, geopolitical and the global health financing crisis, but more on focusing on the domestic aspect. So because of the cutting of the ODA, and also we see that the demand from the populations in the middle-income countries. And we also want to learn from the private sectors, and both for-profit and non-profit organizations. That will be the potential new actors for the health financing agenda. That will be more increasingly important how we can mobilize the different stakeholders for health financing agenda. But of course, not only a benefit, but also we need to address some challenges for the negative implication for equity and also controlling the costs. So today we'd like to invite the two speakers. The first one is Ms. Gina Fadihila. She's a project officer of the Center for Indonesia Strategic Development Institute. So she will share her experience and the case studies from Indonesia on how philanthropic played a catalytic role to support the health financing agenda. And then second, Dr. Festus Susio. He is the CEO of the Mitras Plumbon Healthcare, but also from Indonesia. And he will also share the case study how the private health providers, hospital, can contribute this USA agenda through the public financing scheme. So this hospital, actually, ADB is planning to support for financing this hospital. So ADB is not only financing the government, but also we invest private sectors in the way we promote the direct government direction with universal coverage. So let me invite Ms. Gina for the initial first presentation, followed by the Festus. So welcome.
Good morning, everyone. I'm very honored today to be sharing our paper that we actually submitted last year for the call for abstract. It's about the potential of local philanthropy as a catalyst to Indonesia's health system amidst the declining of official development assistance. So, as we all know, globally, the official development assistance is declining. And from yesterday's plenary session, we also saw how health development assistance for health specifically is going increase in the upcoming years. And then with the declining ODA, there is it might increase the risk of out-of-pocket spending by people, which is resulted by how the services that are previously carried by NGO is now no longer able to provide services because of the cut of the funding. And then additionally, Indonesia is now transitioning to the aging population, where in 2045, there will be around 20% of aging population. So while the ODA reduction might increase the risk of out-of-pocket spending, it also presents an opportunity for the country to explore domestic resources such as the local philanthropy. While it might sound like a drop of water in the ocean, it actually needs to be emphasized that local philanthropy role is as a catalyst, which can provide additional support for the system to move faster. So it's not positioned as something to replace the core financing or to be on the same scale of the core financing, such as the government budgets and other pool mechanisms. So in order to also leverage local philanthropy, it is important to be able to integrate the programs that the local philanthropy are funding that is integrated by the national priorities. While it is sound worth considering. We should also take a look at the potential of local philanthropy in Indonesia. So the health sector is one of the most prioritized programs by organizations in Indonesia, which is ranked number 3 after the economic empowerment and then education. And then according to the value, in 2023, the Indonesian philanthropy support for the SDGs number 3 is also among the highest, which amounts up to 124.6 billion rupiahs. So while it might sound promising, but this also involves challenges, and the challenges are interconnected. So that's why I'm going to present it in a problem tree diagram. So first we take a look at the effects. First, philanthropy fundings are tended to fund short-term programs, which are pushed by the sudden nature of the event, such as disaster relief. But for fundings for capacity strengthening, it's still underlooked. And then there are also a lot of overlapping programs, which can result in duplication of the programs and then can result in the underutilization of the resources, and then also create funding rivalry between implementing partners. And then there is also organizational interest and fragmentation and inequity if programs are not well distributed. And these are the effects from one of the problems, which is the unavailability of resources and role mapping, which is in Indonesia is rooted in the outdated regulation of the local philanthropy governance. And from all those challenges, there are some strategic roles. At the program level, local philanthropy should first start shifting from one-off activities to start funding more system and capacity building, and then start to allocate funding to pilot-based, community-based programs for the elderly as we are transitioning, and then also align the program with national priorities. And it all should be embedded in a system level, which is cross-sectoral collaboration, and it comprises of several items, which are resources and role mapping, so that we can be able to see in the philanthropic ecosystem who has the funding and who needs the funding. And then monitoring and evaluation tools is also important so that the programs that are funded can be evaluated and can have the potential for further funding. And then we also need shared outcomes, which can be based by national development planning documents, and should be also supported in a platform such as regular multi-stakeholder forums, so everyone can sit together to analyze what should be funded and analyze other strategies. And this also should be enabled by updated regulations on local philanthropy governance. So due to time limitation, that concludes my presentation. Thank you so much.
Thank you very much for the very interesting insight. So, especially in the Asian Pacific countries, because of the growing economy, we see that not only the Gates Foundation or Rockefeller Foundation, big foundation, we also see that the growing number of the philanthropic foundation in Asian Pacific, in the local and the country level. We also experience how we can work with this philanthropic foundation more effectively in the additional source of the resources. And that will be potential way that we can work together with the philanthropic foundation. Thank you very much. So the next presenter is Dr. Festas, that he's the CEO of the private hospital, but also he's working very closely with the BPJSK health insurance scheme in Indonesia. So we like to bring this case as a potential future discussion, also how we can interact with the private health providers, including hospitals, private sector providers, and also potentially insurance agency as well. So that will be the kind of starting point of discussion, how we can do this for the next agenda in the next PMAC. Thank you very much. Welcome.
Thank you for the opportunity for inviting me, Aki. So I'm Festus from Mitra Plumbon Healthcare. I would like to talk about a case study where achieving impact through private investment in healthcare. So who is Mitra Plumbon Healthcare? We are a private hospital group. We was founded in 2003. It was not in Jakarta. It was based in Cirebon. It is around 200 kilometers from Jakarta. We focus on the social insurance segment in tier 2 or tier 3 cities, and we offer a comprehensive range of specialties, including OBGYN, pediatrics, ophthalmology, ENT, neurosurgery, ortho, and others. And our flagship hospital in Cirebon is the largest private hospital in Indonesia. It accounts for 720 beds. And other MPH hospitals is constructed with goal to be at 400 until 500 beds, aiming to be largest in each regency, focused on social insurance patients. So right now we have 2,500 beds in total. We have more than 400 specialties among our hospitals. We also partner with private equity from Singapore. They work mostly in Southeast Asia and India. They one of the largest single fund debut in Southeast Asia at that time. So we have been partnering for almost 3 years from 2003. So Mitra Plumbon, it is a family-owned. We worked together from 2003. It was 22 years old company. And this is the background of Indonesia healthcare situations, where it is still underinvested. If you see here, maybe you see the number of beds of Indonesia, the hospital beds in Indonesia, it is account for 1.4 for every 1,000 populations. Whether if you see the WHO standard, it is 1. And if you see the opportunity is here, where West Java is one of the mostly densely province in Indonesia where MPH is located, it's still 0.8. It is still under WHO standard. So I would like to say that our healthcare system in Indonesia is still underinvested. So this is the opportunity. And West Java itself accounts for approximately 50 million populations. 50 million population. And if you see, the number of beds is still under the WHO standard. Overview of the social insurance Indonesia. So we have what is called BPJS Kesehatan or BPJSK. The recent data for December 2025, we have 98.5% coverage all across our Indonesian populations. And it accounts around 280 millions of population. That makes Indonesian's BPJSK is one of the largest single social insurance in the world. So since the inceptions from 2014, the BPJSK started in 2014. So we are very proud that we have covered our Indonesians until 98.5%. And what is the scheme? Scheme is very easy. Class 1, Class 2, Class 3. Class 1, the monthly premium is around $9 per month. Second class is $6, and Class 3 is $3 per month. So mostly all Indonesians are in the Class 3, and it can be paid by themselves or paid by the government. So how about Mitra Plumbon service to this BPJS market? So from our data that we in patients, we have more than 85% across of our hospitals that serve social insurance. And the outpatient admission is we have more than 85% of all of our patients is from BPJS Kesehatan or our social insurance. So what is important that we are very proud that we have served 1.4 million of patients in 2025. And serving the social insurance, we also have to care about the quality. So we are very proud that we have achieved our JCI accreditations in April 2025. And also we have some initiatives such as digital management systems to make everything more seamless and efficient. And we also have offered some state-of-the-art facilities like MRI, gamma camera, PET scan, even our radiotherapy machines. And if you see the growth of our company, since it was founded in 2003, it is 25 beds. We started with humbly 25 beds, and now we are at 2,520 beds capacity in 2025. And we hope that we will increase our capacity, becomes 4,000 of more beds in 2028. So what is important of maintaining the social insurance? So you have to be very efficient in operation. You have also insurance, not only for the social insurance, but we also serve the private insurance. We also check for new potential sites for our capacity to grow. And this is the one that the lady also asked just now. How about the drugs procurement? We have to be very careful on the drugs procurement. And if you see, by having this social insurance scheme, we can push the pharmacy that if you understand that how much the government pay us for a single C-section procedures, it is only $300 US. $300 US we have to pay the OBGYN, the pediatrician, the room cost, the food for the patients, the drugs, the administration cost. It is accounts for $300 US. How about the brain surgery? Brain surgery is $1,500 US. So by saying this, we also have to say to the pharmacy that, hey, please do together. We have only $300 US, and how can I need to pay you like $250 US? It's not possible. So it's one thing that I can say that social insurance also can, by serving social insurance, we can also push and have a bargaining power to the pharmacy. And finance, we have to be very careful of the financing. We have to be very efficient in every part of our costs. And of course, we use IT and digitalizations. And don't forget, we have to be also taking good care of ESG. So now we have 6 hospitals already. We have 10 more sites to build and construct. So hopefully we can achieve like 4,000 or 5,000 beds in 2028. And the most important thing that we are only do it in the underserved cities. So talking about impactful healthcare investment, first you have to be taking care of your quality. You have to have accessibility to the patient, and the most important thing, it has to be affordable. Thank you very much.
Very much for the great presentation. So in many countries, of course, the government and public provider is a critical role, but also in order to increase access to health services, we need to mobilize private sectors. But we little know how the private sectors behave, and also especially interaction with the public health insurance scheme. So we are also exploring how we can capture this information across the region, and then we're happy to update on this as ADV and also maybe work with the other partners in the upcoming years. So this is the end of the program, and we are moving on to the closing session. So finally, I'd like to invite Dr. Precious for the closing remarks. As you know, that she was already plenary speaker for the first day yesterday. So I'd like to hear from you the reflection of the discussion today and the conclusion remarks. Thank you very much, and welcome for joining the session today.
Good morning. I belong to this special group of people who are vertically challenged, pleasantly endowed, but also who show progressive growth. And these are the ones you're talking about, who are aging gracefully. Thank you so much for the discussions. I thought perhaps before I give my closing remarks that we should start by giving the panelists a round of applause. I think what we heard today was insightful, especially in this very difficult geopolitical environment. Several themes arose, but I think I need to underscore what was said yesterday and today about the fact that life is more than just the numbers. So what we heard about the numbers means that we must also reflect on the humanity in us, on how best we care for those who need services, those who need to be looked after. But it was quite a very enlightening discussion this morning, and several themes arose from discussions. And in particular, we heard that sustainable financing encompasses various elements. And fiscal viability, capacity of systems is necessary, but necessary to adjust mainly to these demographic changes and these political seismic changes that brings about uncertainty. And as that happens, we also have to ensure that vulnerable populations are protected throughout their lives, including aging populations, including myself, by the way. So 4 key messages emerge from these discussions. The first is that adoption of life cost investments shifts health spending from a cost control perspective to one focused on resilience, enhancing prevention, and health promotion. But also it helps address the increasing burden of chronic and non-communicable diseases. The second was that experiences from countries, as we heard from Japan, from the South Korean experience, Singapore, Thailand, it demonstrates an important element of integration of long-term care into broader healthcare financing frameworks. And this is important because we have to be responsive and we also have to deal with equity. But we also heard again from the discussions that thirdly, revenue diversification is key, and that strategic purchasing has become increasingly important, particularly within informal and middle-income environments. And lastly, that there are new evolving financing entities, including philanthropies, as we heard, locally, and that these can make a positive contribution, but they can make a positive contribution provided they operate in alignment with public objectives and that there are robust governance structures. We had, of course, the need to bring in alignment different levels of funding streams, local government, and ensure that we can organize the governance of those and bring them to proper alignment and ensure that they are robust. I'll stop there and thank you all for a lovely session.